I have a quick favor to ask. We'll be starting shortly, but Haley and I, it's going to be difficult for us to kind of take notes. I know Katrina said she would help take notes, but if anybody else loves to like play secretary and wants to take some notes, I mean, we greatly appreciate it. And then if you want to share them with us so that we could, disseminate them out. So thanks. Welcome, everyone. Hope everyone had a good lunch. And we are going to, this is workshop 1, the prescription monitoring program roundtable with data submitters and uploaders. I am Melissa Danoon, and I'm the South Dakota PDMP director. And Haley Winans, the specialist with the Michigan prescription monitoring program, is here, and we're going to moderate this session. So what we've done is the NASCA PMP committee has a data integrity subcommittee, and our subcommittee went ahead and prepared for this workshop, and our members devised questions that we want to ask data submitters. And at the very end, of course, there'll be kind of a time when if there's another question that we haven't asked that somebody has, I think the data submitters would be happy to try to answer those. And just one thing to note, this is scheduled for 2 hours. There are 2 other workshops going on. And if we do happen to end early, we encourage you to please go attend one of the other 2 workshops because they're both very, very informative as well. So I'm going to go ahead and get started. And first of all, I guess I want all of our data submitters to introduce themselves. If you can give your name, the company you're with, and maybe just briefly what your role is in PMP data submissions, that'd be great. So let's start with our in-person. Travis, if you want to start.
I'm Travis St. John. I am the Chief Compliance Officer for MD Scripts. I handle approximately 2.5 million records a year being submitted to all the different states.
Thank you. Hi, I'm Janet Hart. I'm a Director of Government and Regulatory Affairs with Rite Aid, and submitting data and updating standards as the state passes the rules and regulations, and then error correction falls under my team at our corporate office.
Hi, Jackie Dugan, McKesson Pharmacy Systems. I am the regulatory pharmacy specialist. So I assist our chain and outpatient customers with recommendations on how to configure our Enterprise Rex pharmacy system to generate the reports that can then be sent on to the PMPs. And we also have a team that manages configuration and reporting directly to the PMPs, the processors, on behalf of our independent and small chain pharmacies.
All right, thank you to our in-person attendees. Now I'm going to call out, we have a virtual option for those data submitters that were unable to be here in person. I'm just going to call out the name of your company. And if you're on the line, please go ahead and introduce yourself. Is Covitris present? All right, how about someone from CVS? Express Scripts?
Hi, this is Heather DeFazio. I manage the PMP process for Express Scripts, Accredo, Freedom Fertility, and Express Scripts Specialty Distribution Services.
Thank you. Kroger?
Hi, good afternoon, everyone. This is Jamie McDermott. I'm a Controlled Substance Compliance Manager for Kroger, and I work between understanding what the state requirements are, and then ensuring that the changes get updated with our technical team to configure that, as well as working with our field teams to make sure that our error correction process is in place so that those are being addressed as well.
Pioneer RX? Safeway?
I guess that's probably me, Charlie Painter with Albertsons Companies. Safeway falls under us. So I'm more on the compliance side. So I assist with monitoring, regulatory changes and ensuring those get baked into our PDMP reporting, and then also facilitating error corrections as they're reported from our stores.
And Script Pro?
Hi, this is Kara Schweigel with Script Pro. I work in compliance and regulatory and help monitor, state and federal regulatory and legislative changes, and certainly that includes PMP. And we make sure then that all of our customers are changes get baked into our system so that our customers who submit in all 50 states are compliant.
TDS?
Yes, this is Margaret Johnson. I'm the compliance manager, and I work with the development, product, and support teams to make sure that all of the changes that are made by the states are in our application for our pharmacy customers.
Walgreens? Dorothy, I have to ask, would you mind coming sitting up here too? You could, sorry. Yeah, you could either sit on the end by Travis. I mean, if that's okay, or that'd be great. And Walmart. All right, well, we thank all the data submitters that are here in person and on the line to join this important roundtable discussion. The format that Haley and I are going to use is we have questions. We're going to go ahead and ask the question. And we think we're just going to basically randomly call on the attendees. And we'll call in maybe 2 different ones to answer each question. Then if any of you other data submitters want to answer as well, we'd be more than happy to have you answer too. So, okay, we're going to go ahead and get started. Okay, so our first question is, and some of these do have multiple parts, so I think I'll just go ahead and read the whole question, and if somebody needs me to repeat something, I can. And I think I'm going to start with, we're going to have Express Scripts and Kroger. If you can address this question for us, that'd be great. When legislative changes or changes in reporting requirements occur that impact the pharmacies you report on behalf of, how do you prefer to receive communication from the state PMP? And in your experience, also share what works well versus what does not.
Hi, this is Heather from Express Scripts. So we do prefer email communication because it typically gives us the date of the new change and gives us the ability to communicate that broadly across the organization. One of the things that we've noticed that doesn't really work well is if a change is being placed in a specification or if an appendix is added without the specific call out. Just because we do dispense to the 50 states, it does make it difficult to sort of sift through those documents and look for changes if they aren't identified. And as for times of year, it's, ideally not 1/1. There are certain changes that we can make that are configurable, but of course, as a IT company, right, we have freezes that typically go through the first of the year. So a lot of the changes, if we can't submit early, say December 1st for a 1/1 change, we run into some issues trying to get things implemented during a code freeze.
All right, great, thank you. And what about Kroger?
Yeah, just keying off what Heather said, I agree with all the 3 points that she made there. And then I'll also just add for us, as a chain pharmacy, anytime that there's changes, email does work best, of course. And we typically are registered with the PDMPs to kind of a general email inbox that's monitored by a few key individuals who kind of review that information and then kind of send it along accordingly, depending on whether it's something that our store teams or field teams may need to know versus something that we need to engage our product teams from, making updates or code changes or whatnot. So for us, really sending to those main uploader or submitter accounts rather than sometimes the changes go to the individual account holders at the pharmacist level, which can sometimes cause confusion. I agree with, anytime that there's changes, 1/1 is not ideal. For us, it's less of a code change issue and more of just a resource issue and timing issue. As Heather mentioned, some of those are configurable on our side, but many of them, especially with changes to formats and whatnot, do require some of those resources on our product team, and having a longer runway, depending on what that type of change is helpful for helping us to prioritize all the additional work that, they've got in the queue as well.
Okay, great, thank you. Next question. And I guess I'd like McKesson and MD Scripts to answer this one. I guess first, is there anybody else that wanted to add anything to that first question? Anybody? Oh, Janet, yes, go ahead.
Okay, one other thing to get the word out would be to go through some legislative groups in the individual states, such as the Pharmacist Association or the Chain Drugstore Association, because they can reach out to many members who may not get an individual slip of paper, but there's newsletters that are sent out, and that's a good way of communication.
Thank you, Janet. Anybody else?
Hi, this is Charlie Painter with Albertsons Companies, and I'm actually going to take my Albertsons hat off for a second and put on an NCPDP hat. I co-lead a task group within NCPDP that does track regulatory changes around PDMP reporting. We do have a monthly meeting, and I recognize a lot of the names in this meeting that do come or dial into those meetings on a monthly basis, where we do track and review regulatory changes. And I put in a small plug that participation in that is always great, and the more people we can have, the better, because then we get better coverage on it. So.
All right, great. Thank you. All right, so I'll move on to question 2. So if, like I said, McKesson and MD Scripps could start answering this one. Are there certain times in the year when it's better for states to implement changes? Are there particular times in the year that states should try to avoid implementing changes in reporting requirements?
Jackie from McKesson, I'll start. I would say that any changes that come due the first of the year or very shortly thereafter are very difficult to implement due to resources being out of the office for the holidays. And we have seen several state changes come in years around the same time, which of course just multiplies that issue. But generally, any other time of the year that you want to make changes to your PMP, it's fine. There's no barriers or any issues at that time.
Travis with MD Scripts. Going off exactly, I mean, Q2, Q3 is the ideal time of the year to have the changes made. That's generally when we're all at full staff. Q1 and Q4 of the year is the worst times. You've got all the holidays, you've got people taking extended vacations, and it's not just on the back end that we deal with, but a lot of your state people are also out. So if you have a lot of questions, you're stuck. You can't implement any type of changes, or if there's an issue that comes up, you can't get help, or you get pushed off, and that just delays the compliance level.
All right, thanks. Is there anybody else that wanted to add to that?
Hi, Dorothy. Oh, one more. Dorothy from Walgreens. Just one other component potentially for consideration is the impact to the patient. So particularly around January, if we change the attribute for an ID to be required, we would just need sufficient lead time to make sure that we can allocate labor to our team members to ensure that we can make the patients aware. And to what was expressed earlier, January might not be the best time. So just to make sure that we're conscious of what the impact is to the patient.
And I just wanted to speak a little bit about the pharmacists and the pharmacy teams during that period of time, because right now it is a very trying time for retail pharmacy as we're working with COVID booster shots, children 5 and above being able to be immunized, and any impact to that process in the store that's an additional step is, it could present a potential issue. So if there's a hot subject that's out there or something along those lines that's impacting community pharmacy dispensing prescriptions, just think about that as you put the changes in, or as you're thinking about the changes.
All right, great points. Is there anyone else? All right, we'll move on to the next question. And for this question, I guess I would ask Rite Aid and Albertsons to address this first. Do you have configurations and or a process in place to report prescriptions to the appropriate state or states' PMPs in compliance with state laws and regulations? Do you have processes in place to prevent duplicate reporting to multiple state PMPs? And I think I'm just going to add to this because I know this was probably my question that got put in here, is that I know in South Dakota, for example, we have a mail order facility. And I know this is probably a little unusual, but we do require that mail order facility to submit all their dispensations to our PDMP, in addition to where they are actually sending the prescription. And of course, sometimes this can result in duplicative reporting. I think that the bigger part of this question is for a pharmacy in a state that is like a retail pharmacy, and if they're actually mailing a prescription out of state. So I had one time a pharmacy in the state of Minnesota and their pharmacy was not actually licensed in South Dakota. And so they would not be able to mail controlled substance prescriptions or any prescriptions into our state. However, they had South Dakota residents that did use their pharmacy. So that pharmacy ended up submitting data to both Minnesota, and they did submit to South Dakota as well. And that pharmacy chain did have stores in South Dakota, and a corporate office was doing the submission. So that's how they were allowed to submit to South Dakota. But in that case, we really talked to that Minnesota pharmacy and said, well, we don't really need this data. The patient physically picked it up in Minnesota, even though they have a South Dakota address. We don't need that to be reported to South Dakota. So I think if I guess you guys could kind of address that a little bit. And I know as a retail pharmacist myself, it's probably difficult to know, in the patient profile, is there a way to indicate in a retail setting in your profile that do you go purely to report based on, do you look at, of course, the domicile state of that pharmacy and or the resident state of the patient in determining, who you're going to report to. So if that makes sense, I'll let you take that, Janet, first. Sure.
We do have configurations in place that allows reporting like that. I will tell you, because I've been doing this a long time, we tried to do that with some states and all of the prescriptions and got pushback from various states saying, we don't need that data. We have interconnect. There's no need to report. And it wasn't just one state, it was several states, but we do have that configuration in place.
Yeah, and Charlie from Albertson. So that's you gave us one of the hard questions. It's we do have our configuration set up to report to the state where the pharmacy is located. And as a general practice, we do discourage our stores, except for very limited instances for patient continuity of care. We don't like sending prescriptions out of state, if at all possible. So, I would tag this onto one of the later topics, but it kind of gets confusing then when you start bringing into account where we do have some pharmacies that are licensed across state lines, typically for the ability to bill Medicaid. So, we have some border pharmacies that are licensed across states. So then, you have to submit something or have a waiver on file. So getting those processes in place is tricky to, set up zero reporting when you do have one of those out-of-state licenses for a retail pharmacy. And we've always not been the biggest fan of waivers in those instances, just because those are, difficult to maintain in those instances. But to this question, we typically only report to the domicile state.
Okay, great. Is there anyone else that wants to answer this question or add anything? Sure.
What is required? What we like to clinics, but so many of our patients are on border states, and they actually reside not in the state where we're shipping the controlled substance and not where they're receiving the controlled substance, but we report based on the patient. Is that correct? Does that make sense?
So I guess first, are you you're a pharmacy then? You're a pharmacist. Okay. So,
We're based in one that we ship to all 50 states.
okay.
For different medications, controlled substances, and we ship directly to the clinic for the physician to administer the medication. We do it for pumps, and but then some of our patients, so maybe we ship to Indiana, but the patient's actually in Kentucky, because Louisville, they're a border state,
So the prescriber that's going to administer the medication is in like Indiana.
yeah, say he's in
Indiana, but the patient resides in Kentucky, but the patient will travel to Indiana to, okay. Okay.
So is there a consensus of, we do it based on patient location?
So you're actually, okay. Yeah, no, it's a good, this is part of why it is confusing. So you're actually currently probably submitting to Kentucky because that's where the patient's address is?
Yeah.
Okay. Well, yeah, and that's kind of what I guess that is a tricky situation. Does anybody want to address that, Travis? You
Are you doing in-off when the prescriber gets it? Are they doing in-office administration? Most states don't require in-office administration to be reported to begin with.
Right.
So it's going to be a very right. But on the doctor's side of it, they will not have to report because they're going to be doing in-office administration. There's only a handful of states that require in-office to actually be reported. To most of them, they treat it as a hospital.
But I guess, yeah, so it's patient specific though, prescriptions, correct?
I'm just trying to I'm here to like clear up.
Yeah.
Issues that we think we're doing, but we want to make sure that we're.
Yeah, well, I mean, I know in South Dakota, yeah, clearly we don't want any, inpatient any inpatient controlled substances, of course, submitted. And yeah, I mean, even if a prescriber, if they're administering controlled substance in their office, we wouldn't want that either. Now, if a prescriber is dispensing out of their office, clearly we do want that reported. I don't know, Jason?
I was just going to add that I believe in our state, don't quote me, but I believe if it's being dispensed for the purpose of administration, then it's not reported. And that's not my official answer. That's what I think it is in our state. And I think the language is pretty similar for many states.
So it's safe to report to the location of the patient then?
I'm saying in that case, it wouldn't require the reporting if it's being
Wouldn't
dispensed for
require
the
the
purpose of
Right.
administration. So that depends on the state specifically what they. Not an attorney. Just my
Yeah.
understanding about that.
Kara?
Well, and I agree with Jason, but I want to just kind of clarify. Even if you're dispensing medication to a facility that then hands that medication over.
They're administering it.
No, I know, but I'm just saying, even if we were to give something to a facility, let's say the facility were to give them a 7-day supply to take home. You would report it to the state where the patient resides, because it's no different than someone who lives in Kentucky driving across the border to pick it up from a CVS location in Indiana and then driving home. The patient lives in Kentucky, it should be reported. That's my standpoint.
All right, so I think, yeah, I guess what everyone's saying with that, you might actually have to, for the definite information, check with the states, that this is affecting so that you can find out for sure. Yeah, because truly, if it's administration, then most programs probably don't need that to be submitted. However, I understand if you're dispensing it, you want to make sure you feel like you need to, but okay.
Hey, I'll interject my perspective, and it basically mimics what you just said. Our pharmacy system Enterprise RX gives you the ability to report to the physical location of the facility and the state to which you're mailing the prescription, or the state to which the patient lives in if it's a retail fill and not a mail fill. So we offer the flexibility, and we leave it up to the pharmacy to determine how they feel they need to meet each state's regulations. So.
Okay, great. All right. So for the next question, I guess we're going to call on Script Pro and TDS to answer this one. And the question is, do the pharmacies you report on behalf of have basic knowledge on how prescriptions are reported to the PMP?
Hi, this is Kara with Script Pro. Yeah, they do. That's part of kind of our training process is to help kind of outline that for pharmacies. I mean, certainly kind of a benefit of our system, and I'm sure others, is the fact that it kind of happens behind the scenes for them. So they should, and they do. I don't know that they necessarily always pay a lot of attention to it, but yes, I would say we do our part to help educate them.
On the TDS side, our pharmacies, they know that, they have to go in and actually submit the report on one of our platforms. We bring it all up in a grid, and then they're able to see if they're missing any data before they transmit it on one of our applications. So they know that's a nightly job that they have to do. On the other application, it is sent for them at the end of the day.
All right, great. Is there anyone else that wants to add to that one? All right. to the next question. And for this one, I'm going to, I guess, call on Dorothy from Walgreens. And we're going to start repeating back. So, and also then Express Scripts. And this one has, I guess, several parts. So I'll start reading here. Do you have a process in place to correct prescription errors that are inadvertently submitted to the PDMP? What have you found works well versus perhaps what has not worked so well? You know, give us some lessons learned.
So we do have a corporate PDMP team. So we do give our pharmacists and our pharmacies a basic understanding of three things: PDMP reporting, PDMP integration, so some minimal troubleshooting efforts, and then mandatory PDMP query requirements. And then additionally, we have a corporate level support team that helps facilitate the correction of any submission errors. We find that this works well for us, particularly because that added layer allows us to identify any root cause issues or any changes that we need to make as part of a corrective action. So our pharmacists and our pharmacy teams have a basic level understanding, and then our support center team is the one that completes the corrections. And also that makes sure that we can get them done in a timely fashion.
Okay.
Hi, this is Express Scripts. So we do have a system to track and correct within the one business day. We've found that dedicated emails to certain individuals in the pharmacy help us just to sort of corral the work and make sure that we get responses in a timely manner. We often include the pharmacist in charge of the pharmacy as well, just to make sure that, you know, it's getting the appropriate visibility that it needs. And we've also found that having some access to the system and knowing how helps us find simple answers to the errors. So for those systems that we do have access to that we can actually review and resolve, we will do that at our corporate pharmacy practice team. Otherwise, we do work with those individuals at each site. I think that's all the questions.
Yeah, that's good. And I know I didn't read kind of the second point, but I think you both really, I mean, address this. I'll just read these kind of other points, sub points that we had. Is there anything else you want to add? So we asked, if you are submitting prescriptions in a large batch from multiple locations, how do you handle getting prescriptions with errors into the correct pharmacy's hands?
So the way that it currently works is we submit the batch file. The batch file is run against a set of validation rules that are specific to each state. And any prescription record that doesn't satisfy those validation rules is manually corrected by a PDMP specialist at our corporate office. So they're the first layer of corrective action to ensure that it's submitted in timely fashion to the state. And then if there's any subsequent steps that are needed in terms of a long-term solution or something else that needs to be done, they also take the appropriate steps at that time.
Okay, before you answer that, let me real quick then, Dorothy. So I think you kind of addressed that. So the second point there asks if, states require that errors have to be fixed within 3 to 7 days. I mean, do you guys feel that you have a process in place to make sure that those are corrected within those requirements?
Correct. And then if it's a larger scale issue, something that can be resolved at the store level, then it's something that we take steps on following the submission of the corrected records.
Okay, great. Yeah. So go ahead, Heather, if you want to kind of address those two sub points, that'd be great.
Sure. So we have a process to identify the pharmacy that it's coming from, and then we reach out to those individual contacts if it's something that we can't handle. And then we typically correct our errors within 24 hours, so we don't have an issue, with the 3 to 7 day time frame, unless we're having to make an outreach to a prescriber, which is a bigger issue than just the PDMP submission.
All right, great.
Pretty infrequent.
Okay, great. Does anybody else have anything to add to any parts of that question?
Yes, this is Margaret at TDS. All of our pharmacies are independent pharmacies, so they fix their own errors. They receive an email from the PDMP of their rejections, and so they are able to fix anything that comes after. We do have things in place to make sure the fields are filled out, but if there's any other corrections that have to be made, then they work with the PMP themselves.
All right, thank you.
And I do have one item to add. We run into a challenge where I think, as I mentioned before, we submit PMP reports on behalf of our independent and small chain customers. And so we are the holders of the dispenser account. And so these error reports do come back to us, and we have some of the same challenges with running through them and determining what exactly the issue is and getting that information over back to the customers. It would be nice if there would be an option for us to maintain the account, the dispensing account, but then have the errors sent directly to each individual pharmacy. That's something that processors could consider.
All right, great.
Yeah, I'd like to add, there's two different types of errors that we have to deal with. I mean, there's a prescription that was incorrectly processed at store level, and that obviously has downstream, consequences that need to be corrected. But then there's also what I'll call more systemic issues. So just as an example, we've just gone through a fairly extensive process correcting scripts in one state where there actually was a configuration issue in how our ASAP files were created. So we had all of our transactions for one state for honestly the better part of a month that we had to work to try to correct. And when you get into that, visibility is what's always our biggest challenge. And getting everybody kind of on the same page to get everybody to be able to get it fixed. So I describe our process as kind of a triangle. I mean, Albertsons, we operate the pharmacies, but then we've got our software vendor that actually does the data submission, and then you've got Apparis or Bamboo involved in this. So nobody has the whole picture of what's going on in a situation like this. Apparis can see the data that's in clearinghouse or aware. We can see the data that's in our pharmacy system, and PDX, our software vendor, can see the data that was submitted, but nobody sees the whole picture. So that visibility is always a challenge. And I know that's, there's regulatory issues involved with that, with granting more access to the data to, more people. But, when we're trying to fix a large scale issue like that, and we're, relying on Bamboo to get us data to look at to see what's actually out there, that causes a challenge for us. So, as far as error correction, I mean, we've had some issues where we've not made that 3 to 7 days correction, just simply because of visibility into the data and seeing what exists in which system.
I guess I want to add too, if anybody from the audience, there's lots of PMP people in the audience. If you guys want to ask something too, or maybe follow up to any comments, I mean, I think that's fine as well. We do have 2 hours, so just raise your hand and let me know. Okay, so we'll move on to question number 6. And for this one, I guess I'm going to ask Kroger and McKesson to answer. Have you clearly communicated PMP uploading and correction procedures to your staff or dispensers, which includes pharmacists and dispensing prescribers? If so, how is this communicated, and how frequently are update refreshers to communication? Do you provide education to pharmacy staff on ways to correctly enter information that resulted in data submission errors?
Jackie McKesson, I can go first. So again, for our chain and outpatient market customers, we generate the files on their behalf and post them out to a secure site where they pick them up and handle all of the submission to the state and corrections that happen thereafter. So they are fully aware of that process and what they need to do. Again, for our independent and small chain customers, we do that on their behalf, and our team is aware of how to retrieve those errors and review them, and then try to get them out to the customers. And those customers are aware of what they need to do within the application to correct and resubmit those records. We send, so for every new customer that we bring on, they get training on how to do that initially. And then periodically, maybe once or twice a year, we do mention it during all customer-wide calls. We'll throw a blurb in there every now and then, a reminder, this is how our reporting processes work. And if you have any questions, let us know.
And Kroger, do you want to address that one too?
Sorry, I was struggling with that mute clicking.
No
Yeah,
problem.
so our store teams, in terms of uploading, there's not a lot that they need to be aware of because that really happens, in an automated fashion on the back end. To the extent that, we have to make changes to the application where they need to collect a different data point or whatnot, depending on what the state requirement is, something like patient pickup ID, for example, we would obviously create job aids and provide communication and training to the extent that there's changes kind of on that front end that they may need to be aware of from an application standpoint. In terms of correction procedures, yes, we use we notify the appropriate state contacts for our stores. They get those kind of validation emails on a distribution list every day that include the error corrections. And then our field teams farm those out to the stores or work with them within their division office to correct the errors. And so we provide information in terms of what's necessary and how to accomplish that via conference calls with our subject matter experts, as well as newsletter communications. Typically, we do that on around an annual basis, or when there's a major change that's happened within the industry, or if we've had issues that have come to our attention from various states where things may not have been handled or addressed as we would have expected them to.
All right. Anyone else want to add to that one? Okay, Jason.
I have a question. Actually, just in simplest terms, do any of the pharmacies have an SOP, a very clear SOP for what pharmacists?
Just in case the people online can.
Thanks, Kevin.
In simplest terms, do pharmacies have an SOP in place to tell a pharmacist what to do when they get a call from a PMP administrator saying that there's an error? I mean, it sounds pretty convoluted. Is there something simple that they could go to in writing that says, when you get a call, this is what you do? Because that is one of the big issues that we run into when we call pharmacies. They still don't know what to do or where to go.
This is from Kroger. Honestly, it hasn't come to my attention that a lot of calls frequently happen to our stores, but we don't have necessarily a specific SOP that specifically outlines that. However, we do provide job aids on error correction and what they need to do in terms of making that correction. We use a web tool where they can go in and correct various fields, and then that kind of goes into the next file upload. Because we don't have them obviously we just have like one data submitter, one or two folks that access the data submitter accounts. But we do provide a job aid for making those corrections.
I know from MD Scripts' standpoint, I've communicated with most of the states that I prefer them to call myself or email myself because I handle all the compliance. It's a lot easier from us to explain how it got there, what happened, et cetera, because a lot of times the pharmacies on the back end, they have no clue. Once it leaves it's in their system, they have no clue until it shows up in the PMP 3 days later. So at that point, they'll call and a couple of the states will essentially email me really quick. Hey, Travis, this has happened. How soon can you get it resolved? Instead of going back to the pharmacist and saying, hey, we've got this error, can you fix it? When they're on a platform, most of the time where we limit what changes they can make. We had an issue in Tennessee about 4 years ago where that created these changes where the doctor was actually going in and deleting records as she got investigated. So we put in stop gaps to prevent that from happening again. And since then, it's worked out great with the states just sending a single email saying, hey, we've got these non-compliance issues. Can you resolve them?
I would absolutely agree with Travis on that in terms of, contacting that data submitter account email so that we can kind of translate what needs to happen down to the actual user or the store team.
This is Dorothy from Walgreens. So I would echo the same sentiments as earlier. It's easier to just get to the source at the corporate office or at the central location. We can probably get the root cause a little bit more quickly. For our team members, we do have a hub. So particularly because there's a lot of new team members now due to COVID and things like that, they might not know a guy. To be able to help with some of those issues. So they are able to search the topic and then their inquiry gets routed to the appropriate team.
So can you hear me? From the pharmacist perspective, that's kind of reverse engineered. From a PMP admin's perspective, we're going to call the pharmacy that's associated with the dispensation. It might not be easy for pharmacists or pharmacy administrators to look at the record, know who the uploader is for that record. So most often, the administrator is going to call the pharmacy and not the uploader, unless the pharmacy happens to be the uploader. So the question was a question and also a suggestion to have an SOP in place for when the admins are calling pharmacies and saying there's an error so that they know what they need to do at that point if we don't have the ability to figure out who the dispenser is, because it doesn't always happen. It's not always very clear who we have to contact for the dispenser, for the uploading side.
Yeah, and I'll definitely take that back as well.
Did you have a question as well? Sorry, Jason, do you mind? Thank you. I guess I should have had a little microphone person. I kind of ad-libbed and decided to have audience participation. But I think it's good.
There we go. Hello. Hello. Yeah. Oh, I'm good. Okay. Kathy from North Dakota. And I'm listening to this, and this is a recurring problem for us too. And we don't have a lot of pharmacies out there compared to most of these states. So I could only imagine what everybody else deals with on a daily basis. But would there be a way to collect the uploader's information and put it into the pharmacy database? And I'm kind of directing this over at Bamboo Health a little. So I don't know, Natalie, if it's a possibility to try to pull that uploader's information into the Aware platform. So when we're contacting the pharmacy or when we're running those reports, that information is automatically in there. And maybe their contact or their email is there so that not only do we contact the pharmacy, but we can also send a quick notice to the uploader, or maybe even have some kind of dashboard for the uploader to see if there's a system-wide problem, if there's a continued error, that comes around over and over again with the pharmacy. Just a thought.
One thing that Bamboo does offer when you log into where your reports are, if you go under the multi-state tool, the states should be able to see who is dispensing, because we have to upload on more than half their states. You have to upload the DEA number. Talking with both Arizona and Ohio, they can see everyone that we report for under our uploader ID. So it would be easier for the states just to get with Bamboo and say XYZ DEA numbers are with this group, because other states are doing it. That's on their platform already. That would be definitely something Bamboo should be able to show you guys, because looking at it right here, I mean, almost every state we have requires that you put it in there. So there's only a couple of them that don't require you to put your DEA numbers in.
Hey.
Go ahead, Jacob. I see you.
Hey. Yeah, so I think we're definitely open to ways that could work better. This conversation has been really enlightening for us. I think it's always a bit of a strange dynamic, because really when states are talking about compliance monitoring, they're looking at the DEA holder being in compliance or not. And so our communications, I think, are maybe geared toward that type of communication when, as is obvious from the conversation today, there are multiple stakeholders involved in that submission process. And oftentimes the pharmacist, that was interesting to me to hear that there's not necessarily even an SOP for the pharmacist when they hear, hey, there's a problem with this. What do they do to that? So I definitely think there's an opportunity for us to step in and kind of help fill that potential communication gap that I'm hearing about. So yeah, we'll definitely take this feedback back to our product team. And I think I have contact information for several of the submitters here. So if you guys could, maybe bounce some ideas off of you on how that could work better.
I'm just going to throw out there that I know in other states can say if this is how your law and rule is written, but in South Dakota, it is basically the pharmacist in charge's responsibility to make sure that their dispense control substances are submitted to the database. So that's like what Jason was saying, that really, and many times, when a doctor calls and says, Melissa, there's a prescription on this patient's report, under my DEA, I did not write that prescription. So I start with the pharmacy because that's where the prescription, of course, was dispensed from. And so I'll ask for the PIC, pharmacist in charge. And, sometimes they have just, kind of like what Jason was saying, no idea like what to do. And they're like, well, can't you just fix that? Can't you go in then? If I tell you it's Dr. Smith, can't you just change it? And of course, I have to say, no, that is not my data. And I definitely don't want to be manipulating the data in the database. And I say that is, your responsibility per South Dakota law and rule to get that corrected. So, if you don't know how to do it, you need to work with your, corporate office or vendor. So, I see both sides of this. I think what everyone, is saying, vendor side, I understand, but two, I think that it does kind of go back to what your state's law and rule is, and so just from our side, for me, it's really, I'm going to call on that PIC, and then it's going to be up to them just to understand what they have to do to get the information, corrected, just so if that makes any sense, maybe for other states as well. So
I wanted to add to that as from a workflow perspective, because I was a pharmacist on the bench before I became a PNP administrator. The first thing is correcting that for the patient, because if there's a medication error, that means that something left the pharmacy that was incorrect. So the first step is to fix that and contact the patient to let them know that an error occurred. After that's been fixed, then the PMP would be fixed. So that is why, the correct order is typically the PMP administrators reaching out to the pharmacy first. The pharmacy makes the correction in the software dispensing system. And then at that point, they would follow whatever the SOP is for notifying corporate if a manual intervention had to be taken, or unless it was automatic when they changed the record in the dispensing software, it would happen automatically. So.
Yeah, thank you, Jason. I should have mentioned that as well, since I also practice. So yeah, the patient's always up, most important to make sure that that's corrected. And sometimes I think too that, maybe if the software is corrected, it's not always an automatic that record is resubmitted. So I think the pharmacist has to, I'll tell them to, once you get this corrected, make sure the patient's fine, or correct your software, the patient profile, but that does not automatically mean that the record will be corrected in the PDMP. So that's something that they should follow up with their corporate office or their submitter. So. All right, well, I think that was great feedback. I think we'll move on unless anyone has anything else for that one. All right, so this next question, I'm going to call on Rite Aid and Albertsons to answer. Do you provide guidance to pharmacy staff on how to enter patient names in the patient profile? And this is probably PDMP administrators, greatest challenge is patient name matching. So I guess I'm really curious, and I probably called on Rite Aid and Albertsons because you guys are pharmacies, and and working in retail myself, back in my day, I always use myself as an example. My name is Melissa, but I grew up as Missy. So I would have been kind of a nightmare. I am sure I would have used Missy at the pharmacy, Melissa at the doctor. So nowadays with PDMP integrations, of course, my doctor is going to, look me up through the integration. Of course, it's going to query Melissa. Maybe patient name matching isn't going to pull in Missy from my pharmacy. So then information won't show up. So, I really think it's important that I try to really tell my pharmacies that please, we have to get on the same page with the name that we're using. And unfortunately, and I'm not sure if, legal name is, or, what name the doctor has and what name is on the insurance card probably should be what's in your pharmacy patient profile, and explain to your patient that for best patient care, you must use the same name, at those three entities for sure. So everybody has a clear picture to take care of you. So I guess I'm curious to see if Rite Aid or Albertsons, do you provide any, guidance to your pharmacy staff to maybe help us in that direction?
Yeah, so we do provide some guidance, and I would actually even add some newer challenges that have come up with, especially with some states making opioid antagonists a drug of concern, and those being able to be prescribed to entities, or whatnot. It adds an additional wrinkle to it. So I'm kind of in the same boat. I'm Charles and I'm Charlie, depending upon where you look. So I'm also an example of this, but we do communicate out that, as best we can if we know that that name should match what's on the insurance card or whatnot. I actually hadn't thought about I don't believe we give any guidance approaching it from a patient care perspective. That's actually a really good call out that I'm going to take back to our operations team, because that's one thing that I don't think is considered and hasn't been communicated.
Yes, we do provide.
No.
I'm sorry. Yes, we do provide information on data integrity to our pharmacy teams. That's a routine communication that goes out. As far as you'll see some issues around juniors, things along those lines. If it's a third, like Jimmy John the third or something like that, there's a question as far as how to put that in there. And unfortunately, sometimes pharmacists may not think about their actions, because sometimes we have a pharmacist that says Janet double count Hart as part of the name. And obviously that's an integrity issue that we address immediately because of characters and everything like that.
I can tell you from my personal experience, I can show you 3 different ways to put my last name, St. John, into the system. And I've yet to find one doctor or one prescriber that can actually figure it out the first time. I've educated more doctors on how to actually do either a period or a space in the last name. And I've gotten with Bamboo in the past, and also when before they were bought out, HID, on how to modify things like this, where you can put partial spellings in for people like myself that have spaces, periods, or hyphens in their name, to stop eliminating the special characters, because certain states do require the license or the insurance card that is on file to be reported to the pharmacy, or shown to the pharmacy to be reported. Well, if you have a case with my last name being St. John, on my license and the insurance card, it says ST period. The PDMP did not accept that at first. They said it was an invalid character. So then some would spell it out, some would just do ST space. It just creates more issues. So the integrity, we've got to have some flexibility in it.
This is Kevin from Nebraska. So Travis, I think you hit it on the head pretty well. It is one of the challenges that we see, where we see names. Maybe some pharmacy dispensing softwares may not have a separate field for junior, senior, et cetera, and they're putting it all in the name field. Sometimes they'll use the name field for special directions. Address field, of course, is always a challenge for that. And how can we have that data integrity to be able to improve patient matching, which is one of the single biggest concerns that PDMPs across the country have, both within the state as well as interstate data sharing and the integrations. It makes it very difficult to pull all those together. So if we can come up with a solution, that's great. If we can have some standardization amongst that.
I'm curious, Dorothy, I'm going to call you out because you're at Walgreens. So what is Walgreens doing with this?
So we do have separate field. Well, I guess it's twofold. So we have a legacy system that we're trying to sunset, hopefully in the near future. And then we have a new platform, both in the legacy system and in the new platform. There's separate fields for each one of those areas. In the new system, there's also a separate segment for preferred names. So particularly if there's specialty patients or things like that, it also differentiates that in order to make the record a little bit more clear. The issue with special characters, though, that is one that we continue to have issues with. So in terms of separating the fields appropriately, that one is a pretty easy one for us. The special characters is one that we haven't been able to solve yet either.
All right, great. Anyone else have any other comments on that one? All right, for this next one, I'm going to call on MD Scripts and Script Pro. Do you have a process in place to confirm that data is successfully submitted to the PMP?
Travis with MD Scripts. Yes, we do. We rely on a 2-factor system. Number one is the reports that I send nightly. I can check our system to verify that they have went through. And the second one is the edit reports we get back from the state. I cross-reference what they received versus what I sent, make sure the numbers match up. If they do, I know we've got a perfect match, and that allows us to move forward.
I guess I'm going to quickly throw in there. Do you want to just answer the next one? It says, conversely, do you have a process to identify when glitches occur and nothing is transmitted?
Yes, we actually dealt with this not too long ago. Our system showed files were sent. However, there was no edit reports to come back to find out that when the SFTP numbers changed, so it showed it went out, but it went to nowhere. So we were able to easily identify where it came from or what happened and how to resolve it in a very quickly manner and had it fixed that afternoon. So it's a easy process as long as you can verify one to the other.
Hi, this is Kara with ScriptPro. Yes, we can see that, a report has been submitted successfully. I will say, since we're not the registrant in any of the states, that we're just submitting on behalf of our customers, we can't necessarily see like the actual error report. So we do rely on communication with our customers to say, if there was a particular error, and either we can help with correction and resubmission when they know how to do that as well. And then the same thing, yeah, we can tell if it was an unsuccessful transmission, but again, if it gets too much further than that, then we would need them to help kind of identify the error message or whatever the other problem might be, and then we can step in.
Okay, thank you. For the next question, I'll call on Express Scripts and Kroger. If ASAP added an additional field to capture, say, discount cards or manufacturer coupons in the method of payment field, would your software be able to account for this and report discount cards into this category, or would there be difficulty differentiating between, say, a discount card and a commercial insurance payment? This is Jamie with Kroger. I'll grab this one first. No, unfortunately, it would be next to impossible in the current way that these discount cards are kind of set up to differentiate them from other commercial third-party plans because there's not a unique identifier for a discount card that kind of, from a BIN or PCN or a group perspective that says, this is a discount card versus any other sort of third-party or commercial plan. There's nothing there in that kind of for us to be able to flag it as such in our plan setup. The common prescription factors are BIN, PCN group, and cardholder ID. And there's not really a standard format that would specify that this particular BIN is always going to be a discount card, for example. Obviously, if there were some of the larger cards, the GoodRxs of the world and stuff like that, it's possible if we'd have to do some development work and make some application system changes to be able to do that. But I don't foresee a world right now with how these are set up that we could 100% capture and be able to tell that every single VIN or PCN, is a discount card or not.
It's Heather. I agree with everything that was just stated.
Okay. Is there anybody else who wants to add to that?
I agree. There's just no way to come back in and find whether or not it's a discount or commercial, because there's a lot of commercial plans that then have their own discount card as well with a different BIN. So.
Okay. And then this next question, it's related to a specific project that's happening. I might not know much about that. Do you intend to work with your clients or customers to align with ONC's Project USA's address standardization and normalization? I don't know if any of you are familiar with that project that's happening. I believe there's a few PMP admins in the room who might be familiar, who could maybe touch on that a little bit.
Kevin from Nebraska again. I think some of you are probably at least aware or heard of ONC's Project USA, meant to help to standardize patient addresses. There have been a lot of stakeholders, HL7, NCPDP, ASAP. vendors across the country have been involved. And this all relates back to the patient matching. How can we improve patient matching specifically for this and patient addresses, having that normalization, standardization with patient addresses? Do your systems allow the ability to have forced functions or education to the staff on doing that, having street as ST or instead of multiple variations, things like that? I know it's early. ONC is hoping to release it by the end of the year for their technical specs. They already did release a version already, but do you have any thoughts on how you as pharmacies, chains, software vendors can help to improve that?
So from McKesson Pharmacy Systems perspective, I am aware of the project. It's on our radar. We haven't had any conversations internally about how we might use it. But I will say we do at least use, and I know this is common among systems, we do use the postal services file to at least verify that we're using a standard state abbreviation, a city that's on file, and the zip code that matches. In terms of the address itself, no, we don't have standards on, is it ST period or is it street? Yeah, again, it's on our radar, no plans as of yet. So we'll see if that's something that we can do, in the near term.
Dorothy from Walgreens. So again, we do have a legacy system and a new pharmacy systems platform that we're rolling out. It is a challenge that we've had. So we're currently in the exploratory phases of how to solve for that, similarly to either this standard or using the US postal addresses for the reasons that were described, as well as the same issue with special characters. And I think Travis alluded to it earlier in the name field, ensuring that people are not putting in comments that potentially might cause quality issues for the patient downstream.
Is there anybody on the Zoom who wants to respond to that or elaborate? Okay, for the next question, yes.
I have a question about the previous question that we didn't address.
Back.
The discount card?
Yeah, about the discount card.
Okay.
Having worked for several of the pharmacy chains, I know for a fact that the identification field after you've entered the bin and the PCN is subjective, especially if there's multiple cards. So a pharmacist goes to enter the insurance card, depending where you are. It might be in the profile part, it might be on the actual dispensation page where they click submit to adjudicate the claim. But there's usually a subjective field when multiple hits come up for a bin and PCN combo where they can choose discount card, commercial insurance, Medicaid, Medicare Part D, or other. I'm not sure what it is specifically what the ASAP field is, but one of the big things was, I remember at least when I was on the bench, that it was a lack of training. If pharmacists understood the importance of selecting the right card to identify that, that would alleviate a lot of the problems that we have when we're actually going through the data. I don't think, again, this is my perspective, I'm not sure that it's a limitation in the software as it is an education thing with pharmacists. So is that something maybe pharmacies can look into to see if that is a subjective field within your software systems? And if it is, stress the importance to pharmacists and technicians on choosing the right card when they're putting in bin PCN combinations, especially when hundreds exist. Or if it doesn't exist, they have to subjectively enter that for consideration by corporate. That would eliminate a huge problem in a blind spot.
Do any pharmacies have, or vendors have a response to that? This is Jamie with Kroger. To the best of my knowledge, I don't believe that we provide a drop-down field for the pharmacist to select the type of card that they're billing to. And I'd have some concerns with having that subjective nature, and that really ended up being, did they make the right decision? Did they pick the right plan? Is it really Medicare versus Medicaid versus whatnot? I'd prefer as much as we could, if we were going to do something like that, to be able to lock that down and have some sort of system configuration that could decide that.
Yeah, Jackie from MPS again. Our Enterprise RX system, it does give you the capability to label what type of plan it is in the administration area of the application, But I will second that in terms of what the user sees when they're adding third parties to the patient profile or choosing which one to bill, it does not show what type of plan it is. So it would be a major architectural change for us to add that ability and then like retroactively populate that for all plans that exist. So not today, but not available today.
I appreciate that. Two chains, which I don't believe are represented, I know have the ability to select an objective field. And I can tell you when you're on the bench and there's 150 different choices, pharmacists pick whatever the top 5 are. They don't look for what it is. So they're picking whatever it is, whether it's discount, commercial, or Medicaid. So just something to consider. Thank you.
Thanks. So for the next one, I have Rite Aid, Walgreens, and MD Scripts. Do you currently report prescriptions when they're sold, or do you report based on date filled? And then if you're reporting based on date filled, or what would it take to transition your pharmacies to report based on point of sale if you're not already doing so? So I have Rite Aid, Walgreens, and MD Scripts.
Dorothy from Walgreens. So we currently report after the prescription sold to the patient. It would be fairly straightforward, just a configurability change to modify which dates are used. We send all of the dates as a batch file. And by all of, I mean, there's 4, the original date, entered date, filled date, and then sold date. All of those are sent after it's sold to the patient. So to modify the configurability or to use an alternate date, that would be a fairly straightforward change on our end.
This is Janet with Rite Aid. We report on dates sold as well. The reason for that is I've answered way too many complaints from doctors in emergency rooms that says that this particular prescription was dispensed to the patient when it was still in our will call section. And so after that happened a few hundred times, we decided that we report on the date sold, and similar to Walgreens, the other fills as well, moving forward.
With MD Scripts, we do both actually. We handle a bunch of dispensing practitioners, and with dispensing practitioners, we do it the date that is sold, which will also be the date that is filled. Then there's other instances with the pharmacies. We do it with the pharmacies on the date that it is sold and walks out the door.
And then this question actually has a few parts. So for the same 3 or anyone after that, if the pharmacies report based on filled, how are return to stocks handled? I would assume, but maybe you can clarify, a void is sent to the PMP when it's returned to stock. And then the second question, if a medication is filled, reported, and then returned to stock, how long does the medication or the prescription remain in the fill status and reported to the PMP before it gets returned to stock and voided out? So I guess if it's reported when it's filled, how long is it remaining in that will call status?
With most states, the day that is reported and they let us know that a void needs to take place due to customer non-pickup or something else, I can rescind the void that evening. It's generally taken out of the state's PDMP within 2 to 3 days, with the only exception being California. Atlantic Associate only processes voids once a week for their few states, and that happens on Wednesdays. So sometimes it can take up to 10, 12 business days for it to come out of their system. But on the other aspects, as soon as we're notified of a void that needs to take place, it is done. And that record is submitted that night, then Bamboo very next day accepts the file and submits it over to the state. So about 2 to 3 days on average.
Does anyone else want to add anything to that?
One thing that I could see being a challenge to the original question, changing from date sold to date filled, and like sounds like most everybody does date sold, we do date sold as well. If you were to transition to date filled, due to different workflows that different pharmacy systems have, you kind of got to decide where you're going to snap that chalk line. Is it when the prescription is processed? Is it when it's adjudicated? Is it when pills are put in a bottle? there's more ambiguity in what actually is the date filled for PDMP submission versus date sold is, when you gave it to the patient. That's clearer cut. So, such a transition would definitely need some consideration there. I definitely think such a transition would also, make more sense as states potentially look to moving to closer to real-time models. Date sold works well with batch, end of business day type reporting, but date filled would probably, in my opinion, would be more conducive to a real-time model. To the bullet point about filled, reported, return to stock, that always adds challenge and kind of gets my blood pressure up a little bit, because anytime we're modifying data, you're just adding an additional link in the chain that could fail. So especially if you've gone to real date filled, and say you do it when the claim is adjudicated, what if the patient requests the prescription on their insurance, and then, oh, I want to try it on a discount card. So you've reversed your adjudication and re-adjudicated it on a different plan. Each time that happens, I mean, when everything works right, it should be fine. But every time you add another link to that chain, you add another place where it could fail.
Are there any vendors or data submitters here or on the call that report based on date filled, or has everyone, I know MD Scripts, you do both, but does anyone do date filled, or has everyone kind of converted to the date sold?
We have a both ways. This is TDS, it's Margaret. If our pharmacies do not have a point of sale, then obviously they're off of the date dispensed or filled. It's the same date because we have no way of tracking that. We do try to make several different options just to have like a picked up signature, not necessarily the full blown POS system. If they just want to do a signature capture, to try and alleviate that, because as soon as with the signature capture, it then tells the pharmacy it's been picked up. So we can do it off of that, but it's hard to get them to buy into just getting some sort of a way to communicate between when it walked out the door and when it was actually dispensed.
Okay.
And then from McKesson Pharmacy Systems, I will clarify. So our Enterprise RX system does always report based on the date sold, and that is the date that the prescription was physically handed to the patient, or the patient's pickup person, or mailed to the patient. So that is the sold date. I'm air quoting sold date. That's the date that we consider it sold, and we report it to the PMP. We do also have 2 additional pharmacy systems that I didn't mention, but they are on the verge of being sunset. But if anybody is familiar with them and you were questioning why I didn't mention them, that's why. So they are Pharmacy RX and PharmaServe. Pharmacy RX reports on date sold, but PharmaServe, for some of the states, they have it configured to report on date sold, and for some of them, they have it configured to report on dispense date. And I'm not exactly sure what the decision is for each. Maybe it's based on some rules that the PMPs had in place at one time or have in place now. But that we do have configuration both ways in that system.
Okay. The next question, I have Albertsons and Script Pro. Is it a challenge to report prescriptions for animals to the various state PMPs? And if you could change something about the reporting of animal prescriptions, what would you change? And then there's a third part. Does your pharmacy's software include fields in the patient profile that directly link to the PAT20 and PAT23 ASAP fields?
Yeah, so for our pharmacy software, it does, as long as the pharmacy teams correctly identify that patient or that patient as an animal. It then prompts them, they actually have to associate it with a human owner. So if there's one weak spot in that process, it's that it does require the pharmacy team to identify it as an animal. This kind of goes back to our previous conversation about naming conventions and whatnot in special characters, because I think everybody would agree you probably see special characters on animals more than just about any other patient in your system. So that's always a challenge. But you know, I know this does seem to be a focus of the states right now, ensuring that the animal scripts are reported properly, and our system does have those fields mapped appropriately.
Yeah, this is Kara with Script Pro. I'll just say ditto to everything Charlie just said. Yeah, it's not really a problem as long as the pharmacies have done their due diligence just to identify an animal. We've got the appropriate fields, and we do some, you know, additional training just to make sure to call that out so that they know, like, if it is a pet prescription, please do the following steps. But otherwise, it's not particularly problematic for us.
Does anyone else want to add anything?
Can you hear me again? This is Janet. I think one of the other challenges is that if there is a reporting of a pet owner, there could be several pet owners and you may not have the same information. You could have a husband and a wife. You could have a child that reports as a pet owner. So there is some confusion out there, or thus some confusion to the pharmacy teams about that particular data field.
This is Kevin from Nebraska. I just wanted to let everyone know that there is a lot of confusion, as we all are aware, with veterinary prescriptions. NASCA and TTAC have formed a joint work group to help better understand and provide some best practices on reporting of veterinary prescriptions. That should be out relatively soon. I think that might help some confusion as some of these best practices.
So it's Dorothy Walgreens. So one item that would make it a little bit easier for us also is the state specific demographics from each profile being aligned. So what I mean by that is one state requires the owner's let's say gender or date of birth, and the other state requires just the date of birth. So just aligning on which attributes should be selected from the owner profile and which attributes should be selected from the animal profile. That would make it a little bit easier rather than having it configurable for each state.
The next question, again with animal prescriptions for TDS and Express Scripts, do you have a process in place to prevent uploading of veterinary or animal prescriptions in states that do not collect those dispensations?
This is Margaret from TDS. We do not. We would report the prescription based on the fact that it was a controlled substance, but we always send the PAT 20 and PAT 23. So we would have the owner. So when we'd always be sending the species and then the animal's name. So hopefully that helps the PMP see that, you know, it was for an animal, and they can toss that out if it's not required, but we do not have a way to prevent the filling of it or the reporting of it.
And this is Heather. We're no longer dispensing pet meds, but we actually did implement a process whenever we were to exclude animal prescriptions for states that did not collect.
Okay.
And for McKesson Pharmacy Systems, I'll say that our Enterprise Rx system has the capability of excluding veterinary medications. I will admit that I am not confident that all of our customers have that configuration in place. So as PMPs, if any of you see a pattern where you're receiving veterinary prescriptions from certain customers and you've reported it to them, you know, they can certainly come to us and we can help them get the configuration in place.
The biggest question I have about it regarding all of the animals, veterinarians, we have a standard for humans under the ASAP formulary where you go 4.0 to all the way to 4.2B. There's a set standard. Why can we not have a set standard for animals or any type of veterinary patient? I mean, if we can do it for one, why can't we do it for the other?
And then the next, oh, Ralph.
I think the difference really comes down to how the law is written in the particular states. So like in some states, it will say that the owner of the animal must be on the prescription label, and that's in the Drug Control Act. Other states don't have that information. So to get to your point, we would have to go to the, we'd have to recognize, we'd have to research the states that have that one issue. We're waiting for the report that Mr. Kevin was talking about, and that will give states to the chance to maybe look at their legislation and come up with a better way. But I think it's a good point, but I think it's a legislative issue.
And here's the big reason why this question is important is very simple. You have some states where the animal first name is in the first PAT field. The second is going to be the owner's last name. Then you go all the way down to PAT 23 where you install the pet's name again, but then you go back to the date of birth. Some states want it to be the owner's date of birth. Others want it to be the animal's date of birth. There is no consistency across the board. And so it creates mass confusion.
For the, go to the next slide. For the next one, I just have it open to anyone, any of the vendors or data submitters. Are there any issues? Well, I guess anybody in the room. Are there any issues with zero reporting that you would like to discuss? None?
This is Heather.
Okay, rock and roll.
No, no, there is. No, this is Heather. I think just the inconsistency, right, of who requires and who doesn't. I think the other thing that we've noticed is that there are a couple of states that require error in CDI placeholders in their reports, which requires additional coding. Mm-hmm. And then selfishly, a lot of the states don't permit, or vendors don't permit, alternate identifiers. So, NPI versus DEA. So it requires a lot more waivers to be maintained when, we still would have to zero report otherwise.
Okay. And then, Katrina.
This might be directed at MD scripts because you mentioned that you have dispensing practitioners that you report on behalf of. But to anybody that reports on behalf of dispensing practitioners, have you been able to automate zero reporting for them?
We've been automating zero reports for close to 6 years. That's something that was actually really simple to do. It's actually easier to do a zero report than it is to do data most of the days.
Yes, we've been automating zero reports since basically the beginning. So.
Okay, and then the next question I have for Kroger and McKesson, for states that require drugs of concern or non-controlled substances to be reported, are there challenges in reporting the prescriber's information?
This is Jamie with Kroger. I will say, I think over the last couple of years, this has gotten better. As a few years ago, as we saw states adding drugs of concern that weren't necessarily controlled substances, it seemed like they had edits set up, to kick it back if there was no DEA or there wasn't any direction on how to necessarily handle it if there was not a DEA. So I'd say by and large, it has improved. I know we have an outstanding issue in Wyoming at this time that we're waiting on a little bit of guidance as far as what to submit there as it's kicking out some errors. But generally it has gotten better.
For McKesson Pharmacy Systems, we have a challenge with reporting the appropriate ID for prescribers, for veterinarian prescribers, for controlled substances. If I'm going to take a broad stroke at how the states require it, I think I've generally seen that a veterinarian isn't going to have an NPI. So if the state, if the PMP is requiring an NPI to be reported for a controlled substance, we don't have logic right now to say only require an NPI for a non-veterinarian prescriber. And conversely, in those cases, I've seen where states PMPs say, okay, you're not going to have an MPI for a veterinarian, so we would like you to report the state license number. but it's only required for veterinarians. So in the converse scenario, we don't have logic right now to only requirement for veterinarians. So we're working on that, but it is a challenge for us right now because since we can't require it across the board for all types of prescribers, we currently have it set to what we call reportable only. So if it's in place in the prescriber profile, then it will get reported, but it's not being required at this time. And so you can see how the data might be missing in some cases, and then we have to go fix it after the fact. So I don't think, to clarify, I guess there's nothing really that you all can do about that, I don't think, but we do have a challenge with that right now.
I'm curious, because you kind of talked about the logic there for veterinarians. Hey, this is Jacob with Bamboo. Is there any consideration about logic that would be sort of drug specific? Because a lot of times the requirement is, if it's gabapentin, for example, there are going to be submitters or dispensers, in fact, who may not have the DEA, which would be the typical requirement for that prescription. So that's the scenario from the Bamboo Health perspective where we would expect to see that NPI come in. So it almost seems like the logic should be based on the drug not being a schedule, maybe drug schedule as opposed to prescriber type. I don't know.
So I'll say from our perspective, we can set the prescriber ID based on the schedule. So we do, for instance, DEA number, we have set to only require it if it's a scheduled prescription. So if it's a gabapentin and it's a state who only considers gabapentin a drug of concern, we will not require a DEA number for that. If that helps clarify. Now, in terms of NPI, we just leave it as, if an NPI is required, it's required. We're really looking for a way to just distinguish between veterinarian at that point.
From MD Scripps' standpoint, we have to create special logic across multiple states for the gabapentin specifically. For some fact, it is a drug of concern in a lot of the states now, and you don't have to have a DEA number. So we've had to go make special logics for certain drugs of concern, which it does create more issues, but at the end of the day, it's an extra step we've had to take, and it does take a lot of challenges to get it all done and make it flow smoothly with the rest of the logic, because we have certain drugs that you can sit here and have it submitted through without it getting kicked back for missing a DEA number or missing NPI on vets. So there's definitely challenges.
One thing I'd like to add on to that is I know there are at least a handful of states that also then have a prescribed, dummy NPI or dummy DEA number that they would like submitted in those fields, and sometimes finding that data, or I guess I should take one step back, or some states that I'm going to use pharmacist prescribed naloxone as an example. They want the store's DEA number to be submitted as the prescriber's DEA number. So the challenge in tracking down all of those variabilities from state to state is a big challenge for us. So if there was some sort of a resource that could be put up, or at least made more prominent so that it was easier to identify in those instances where a state has a set data field they want for drugs of concern in those instances.
And this Dorothy from, oh, sorry. Dorothy from Walgreens, we have the same concern, particularly for veterinarians and then for drugs of concern. There's some states that have, for example, 13 drugs of concern. So it's quite a high volume that needs to have a specific configurability or what was said earlier, like a default value, and the level of complexity to build those configurations specific to each state becomes just, it would be easier to have something in a generic format across all states for the DEA and for the NPI.
And I was just going to add, I think that the challenge with some of those other identifiers is that from keeping our pharmacy system and our system of record clean, we don't ever want a user to input a dummy DEA or a placeholder, and some of the fields have data validation that we couldn't even enter something like that. And so the way that those come back to us is they get rejected, and then we have to correct them manually elsewhere. But, that's not something that we're ever encouraging our pharmacists to do or our technicians to do, is to enter those values up front. So it just creates additional work on the back end.
I would agree. The pharmacies, many of us have scrub systems in place that bounces up against, the federal DEA file on a daily basis in order to keep the dispensing clean. And with a dummy DEA, it comes out every day. So there has to be some way to stop this problem overall.
Okay, and then the next question I just have open to anyone. Is there something you feel the vendors of PMPs or PMPs are doing well? And are there any suggestions for improvement?
This is Travis with MD Scripts. Biggest suggestion I can make, especially for uploaders, on an average day, just from Bamboo, I get 2,000 to 3,000 emails a day. There's days, especially on the weekends, I'll come in on a Monday or a Tuesday and I'll be 10, 15,000 emails behind, for the simple fact that I can submit one file, but yet I'm going to get 800, 900 out of that one file because I'm going to get an email per DEA number. Tennessee is one of the worst ones. I send one file, I get 500 emails back out of one file. So if I go on vacation or whatever, I've come back to 30 or 40,000 emails that's virtually impossible to catch up with. So you just mark them all as read, throw them away. And then you go into the state system and you literally just look for the failed files and send those back to you. I mean, it's just the easiest way to do it, because if that process isn't resolved, you're never going to catch up. You're going to spend all your days just going through edit reports and you're never going to get to the other issues.
Natalie?
So I think what we would need to better understand is, so like, for example, most states require, and it's really in a number of state contracts and RFPs, that that we send an email that includes the error detail to each individual pharmacy. So in your case, obviously you're submitting on behalf of a number of pharmacies. And so what would be a better situation? Would it be like you got one, like a summary, or what would solve that for you? Because we have to be able to notify you, obviously, with that detail, but what would be a better user experience for you?
We actually approached APRA/Bamboo more than a year ago asking for a daily file, one file with all the errors on it, and we were told it could not be done. So at that point, we've approached it again. We've even offered different things, and we've always been told, we'll look into it. We'll never get anything. We've taken it up the chain as far as we can go, and it stops.
I got it. I can try to track that down. I'm not sure who you spoke with, but I'm happy to try to look into it.
Because I mean, definitely the biggest issue we have is like Tennessee and a few other ones. I get on Washington alone today, I got 483 emails just from Washington. And so that's 483 emails I've got to go through just to click to make sure everything went through. Or I can go to the clearinghouse's website, look at the single file.
Yeah.
And it shows it's all there, but yet I get all the emails for all the DEA numbers.
Yeah. Okay. Yeah, I'll try to track that down. I don't know all the details technically, but I'm sure there's a reason why I don't know why we couldn't, but I don't know much. So, but we'll try to get more detail.
Yes, ma'am.
Ralph.
I'm Ralph Orr with Virginia. I think my question would be, as a PMP admin, is that I want somebody to know about the errors that need to be corrected so they can correct them. And maybe you as the vendor doing the reporting isn't the correct person, but the problem that we get, or the feedback we get, is that the pharmacy doesn't know that they had an error that needs to be corrected. And so, I'm quite fine with if they can be worked out, if it's a daily file or something, but it's the biggest concern I have is making sure that the errors get corrected. And how do we communicate that to the pharmacy? How do you collect that information to correct those errors from the pharmacy that did the dispensing?
Once we get the edit report back, we send out a copy of the edit report to the DEA numbers. We parse it out to where each pharmacy or each DEA number would be in a prescribing dispenser. They get a copy of the edit report as well, showing what got reported, if there was errors. Then also on my system, when I do my cross checks every day, I can look at it and see if there's an error. And generally, most times by 10:30 to noon, I've already called them and said, hey, this is what error you have.
I had a question around the fault tolerance threshold. So one of the options in clearinghouse, I guess, is to reject a file if 80% of the records have an error in them. So, okay. And we kind of have gone, I'm in Virginia as well. We've gone back and forth on whether we should enable a fault tolerance threshold, or, if there are 100 records submitted and 5 of them are accurate and 95 are not, don't we still want the 5 accurate ones? But I understand there is some issues around resubmitting an entire file might be more efficient than correcting 95 of those 100 submissions that are have an error. Is there any idea around, for you as a submitter, some of you are such large submitters that might have different kinds of considerations, but is enabling a fault tolerance threshold, does that make it easier for you or worse for you?
This is Jamie with Kroger. I've had minimal experience with this, but generally speaking, if we were to get an error report back from a state where the majority of our records had errored out, we would ask our technical team to just completely, first we'd obviously figured out what went awry there and make the correction however it needed to be done. But we would ask them to just completely regenerate the file and resubmit it. So I think that there could be some usefulness in creating some sort of fault tolerance, and we'd obviously need to kind of think through maybe some negative downstream effects on that. But just thinking about what we normally do when there's a large percentage of errors on a file, I think it makes some sense. There's some sense to it.
DMP query, which all states don't have for dispensers. And so on the states that do have it for dispensers, again, we have so many border clinics and the patient's located in a different state. How, I'm just wondering, like, take a consensus, which states do you query? Like, do you query based on the patient location, or do you query on the clinic location, or both?
Do any states here require their pharmacist check that can answer that, or their dispensers?
So we don't prepare for dispensers, but we get this question a lot from pharmacies because we have so we have so what I was going to say is, at least in Indiana, I know that our mandatory use law says if you are licensed in our state, then it's mandatory for you. If you are not licensed in our state, regardless of whether or not you're treating someone from Indiana, you're not required to follow that statute. Oh, really? Well, right. We get a lot of questions about that. Right. Yeah, we do get a lot of questions, but the law specifically says if you are licensed to practice in our state, then you have to follow the mandatory use laws. And I would imagine that's pretty standard across the board, because we can't mandate that someone licensed in Illinois follow a certain law. They're not licensed in our state. They don't work in our state. We cannot create laws for other states and practitioners working in them. So.
Okay.
On, are you can, okay. We have a problem with interstate sharing because we do dispense to all 50 states and to a patient, I think in DC. Who can I petition as a dispenser to be able to have more interstate sharing that's capable, but it's not necessarily available? Because I practice in Mississippi, and for instance, we have patients we have two pharmacies, one in Mississippi and one in Texas. And if you are looking on Mississippi's PMP, we can't query Pennsylvania, but if you look at Texas PMP, you can query Pennsylvania, and it's the same platform. So how is it possible that as a dispenser, we can request? I've been told I can't request as a dispenser. That's a state decision. But is there anyone here from these states that can grant interstate sharing?
So it is, the interstate data sharing is up to the individual state and what roles are allowed. That's all configured at the individual state level and what states they're connected with.
Okay.
I don't know what state were you?
I'm in Mississippi, but we have another branch that's in Texas. And so I think Pennsylvania has required PMP query, and we can look it up on, and I'm licensed in both states, so I can just go under Texas PMP, but some of the pharmacists in Mississippi are not licensed in both states, but we're still dispensing under our pick. So I'm just we're trying to clarify, like, how can we make this easier rather than logging into so many different PMPs?
Right. Yeah. And even not just the interstate data sharing, the connections that you're logging
Yes.
into one state and checking another.
Yes, that would
Who
be.
has access to a state's PMP is dependent on the individual state's PMP laws and who
Okay.
they grant access
So
to.
it would have to be petitioned to the state.
You would need to talk to each individual state.
Okay.
Yes. Mhm.
So it's not just a question, some states.
Mhm.
Very unique
Thank you.
situation. It is, and I don't know if she's aware of it and aware of what you're doing, or if the Board of Pharmacy is aware of how you're handling your business. I didn't know you, every time you talked, I was wondering where you were from or what you were doing, but just talk to Stephanie about that, because she's absolutely right. Pennsylvania may have something that says we can't share with them. And if this, you know, from my perspective, it would not be appropriate for you to go through Texas if you're sending it to, you know, Pennsylvania to get Pennsylvania. I mean, you know, if Texas is sharing, that's not appropriate if you're sending it from Mississippi, you know, so we need to make sure that you're doing those things correctly. Yeah. So, yeah. I understand, but being located in Mississippi is a little different because, you know, your pharmacists are in Mississippi. One of your physical locations in Mississippi, you know, that's because you are required to, you know, pull a PMP on who the patient is. So, you know, I don't know. Well, you should be able to see when you get in, you should be able to see every state we share with. And if you don't see that state, we're not sharing with that state. And if there's a state that you specifically need, you know, you tell her, you know, or ask her, why are we not sharing with that state? And then you're just gonna have to let her handle, you know, the semantics of, you know, sharing. Correct. No, and you shouldn't be expected to, but there's a reason why we're not sharing with every state. You know, and some of them it's just because we just haven't communicated. So.
Reached out to them yet.
And I would add to that, we get a lot of calls in Delaware about that. It's really important for pharmacies not to just pick and choose states that they use to search other states just indiscriminately, because there are laws, privacy laws in place. I'm not accusing you of anything, but we get that call a lot saying, I found a state who has access to all these other states and we're using that. Is that appropriate for your statute? And absolutely not. You have to make sure you're following the statute of the state the patient resides or wherever you're licensed. So there are some pharmacies that are very ambitious and dispense in all states and they have a license in every state. And that makes it a little bit harder to kind of keep track of. Yeah. So yeah, most of us are willing to, we work with each other as best we can to try to make connections. There are some states that aren't interested in connecting with other states if they're not close or if they don't see a need for that. But if you make your case to the admins in that state that you have an active pharmacy and patients, I think pretty much anybody would be reasonable.
Are there any other questions or topics to discuss? We have about 5 minutes left. And for those on the Zoom, I know we lost connection. It's just open floor right now. If you have any questions for other data submitters or the PMPs or the vendors of PMPs, feel free to ask.
Jackie McKesson again. I have a question for the state PMPs, please. When it comes to reporting, it's kind of off of what we were just talking about. When it comes to reporting prescriptions to states where the controlled substance is being mailed to, states that require that, is it you're only requiring that for pharmacies that are licensed in that state? And maybe I'm asking the question wrong. Do you also require a pharmacy to license in your state to be able to mail into it? Seeing nodded heads. Okay, just making sure. I will state what our product does today is we don't know whether or not a pharmacy is licensed in the state in which they're mailing to. We're not tracking that. But if a prescription is mailed to a particular state, we do report the fill to that state. So.
Ralph?
So I have a question for the reporters, the vendors. There's been some questions going around in some of the PMP community as to whether PMP should collect race or ethnicity information. And before we really start looking at base app standard, I kind of would like to get an idea of how submitter data, the dispensers and the data submitters, what do you think about that? How difficult would that be and how would you do it?
I mean, we've gotten some experience with that, with having to collect some of those types of fields with vaccinations, with COVID vaccinations today. I can tell you, I'd get massive pushback from my operators because while it's just a simple a simple matter of choosing something from a drop down. It is an additional step that they have to do. And then this gets into areas where you start putting pharmacy teams in difficult situations because they're then asking patients for things that, we're just getting a little bit further outside of comfort zone about what conversations they want to have.
So this is Dorothy from Walgreens. I'm not sure, is there anyone from North Carolina here? So that's actually a question that came up in North Carolina. So for immunizations across a couple of different states, we do submit race and ethnicity. It is appropriate because you're having a clinical encounter with the patient at that time. We don't have any issues there. There was recently a request by North Carolina to submit race and ethnicity as part of the prescription record. That was actually removed due to some of the issues that were described, particularly because it was specific to state funded beneficiaries. So from the patient encounter, you would be asking potentially Medicaid patients for their race and ethnicity, and then a commercial payer patient, you would not be. And again, just really that was a difficult question to kind of think through. And at the end, it was removed from the prescription record. However, it is still being retained as a submission as for the immunization records.
Are there any other questions or topics? Okay, well, it looks like we have 2 minutes to spare. I thank all of you data submitters and vendors for joining and traveling here and joining this 2-hour Zoom session. We appreciate it. I hope it was informative for you and you as the PMPs here today in the audience. Our next session is at 3:30 back in this room, and thank you all.
Thank you.